So our next speaker is Dr. Basappa, who is currently a medical oncologist at the Cross Cancer Institute in Edmonton, Alberta. He is an assistant clinical professor in the Department of Oncology, Faculty of Medicine and Dentistry at the University of Alberta. Dr. Basappa obtained his MD at the University of Alberta. He received training in internal medicine at the University of Toronto, and later went on to complete his subspecialty training in medical oncology at the University of Alberta. He followed this up with an experimental therapeutics fellowship with a focus, I'm not going to be able to say this, on genitourinary cancers at Cleveland Clinic in Cleveland, Ohio. Excuse me. Dr. Basappa's clinical and research interests focus on the management of genitourinary malignancies, and he is the principal and co-investigator of multiple national and international clinical trials. He particularly has a special interest in kidney cancer. Welcome, Dr. Basappa.
Thank you for the introduction. My name is Naveen Basappa. I'm a medical oncologist here at the Cross, and I was just telling Sue that I've been working here since 2010 after I completed my fellowship training in the States. And it's been great working here. Edmonton is home for me. You know, I'm homegrown. I'm an Oilers fan for life, so it's nice to be here and give back to my community just as they gave to me when I was growing up. So I'm going to speak about systemic therapy in advanced renal cell carcinoma. And I know that I'm certainly going to touch upon and discuss immune therapy and how that novel therapy it's making its way into the armamentum of managing kidney cancer. But I did want to lay the foundation. I do recognize a lot of familiar faces in the room, patients and patients' families that I've seen before, but also there's some people here that I haven't met before. So if you haven't gotten used to me yet, you certainly may by the end of the talk here. So just to start, what is advanced renal cell carcinoma? And Dr. Moore certainly did lay a great foundation for me going forward here. But it's basically advanced kidney cancer, if you will. And what that's saying is basically cancer that cannot be surgically removed to give you that cure. And in the setting of advanced kidney cancer, really what we're trying to do is try to control the disease for as long as we can and as well as we can, and give patients that longevity. All right, so it's not something that's going to go away. The cancer is unfortunately not going to go away. We typically can't cut it out anymore, but we want to be able to try to control it. And so really that's what the treatments are aimed at. So these are some of my disclosures, which aren't necessarily applicable to this. So this is what I'm going to do. Now, I've given some talks before, and I was thinking to myself, oftentimes I start talking when I see patients in clinic, and I just start prattling on, and I don't realize that I haven't really laid the foundation. So I stop and I go back, and I just want to cover some of the cancer basics for those of us here that may not quite understand it. All right, and if you do, then I'm sorry that you have to go through this again, but that's what I'm going to cover. Next, I'm going to look at what are our current systemic therapy options. Just a brief overview. Again, most of you have probably heard this before, but also giving the landscape. Some of you in the room are patients or patients' family members who are at a certain stage of treatment and don't know what's beyond, and so we'll cover some of that today. I'm going to go on then and touch upon immunotherapy and where treatment is maybe going now in kidney cancer. And I'll have a little video there that'll be a nice primer before I go into talking some of the novel therapies as I just alluded to. So, here's a nice slide that I managed to get. It was available on the NCIC website. And really what you're seeing here is basically on the top half here is what normal cells do. Normal cells grow and divide, and as the cells get older, they will slowly die via process of cell suicide or apoptosis, and new cells will come in to take their place. All the while, these normal cells are respecting their boundaries and where they are and their environment. They don't grow beyond, they don't grow less. They're very much in control of their growth and what they're doing. Now, sometimes cells can undergo some damage. As they're being replicated or copied, there's a little, as you say, maybe a deletion or a change in their programming that makes them not as normal anymore. And in the bottom half here, you can see through a succession of errors, if you will, in the process or mutations, cells can become more and more uncontrollable to the point that they become malignant or cancerous, and that results in uncontrolled growth. And that uncontrolled growth is the byproduct of basically cells that have been damaged and just don't respect their environment anymore. And they don't understand, or they don't have the proper cell signals to say, hey, I'm going to stop growing. This is as much space as I've got. I don't need to grow anymore. No, they're going to keep growing and growing and growing. And that's a cancer. There's a real delay in this, isn't there? All right, that's fine. So this is a slide looking at invasion and metastases. So in the top slide part, just pretend that that's a section of kidney there. And all the green cells in there are some small cells that have had maybe a few small hits, so a few small mutations. So they're starting to grow a little abnormally. And over time, in the second picture, if you will, there, you start seeing the darker green cells. Those are the angry cells. Those are the cells that are starting to grow and not really respect their environment. And you can see here on the bottom part of that second picture how the green cells are now starting to grow into the tissues surrounding the kidney. Now that's an aggressive type of cancer. Now that's an invasive cancer that pretends to, again, a cancer or malignant cell. And finally, in the third picture here, what you're seeing is, again, those angry green cells, again, invading into the surrounding structures, not staying where they're usually supposed to be as the normal cells, and then getting into the bloodstream or lymphatic vessels, as Dr. Moore may have alluded to as well, and starting to spread. So that's how cancer grows, and that's how it eventually spreads. So those are kind of the basics of cancer, if you will. So that's how your cancer grows. Now, certainly a lot of patients in the room have cancer that has spread. And that's the process by how cancer does it. It gets into the bloodstream and travels to other parts of the body. So in terms of nomenclature, or terminology, if you will, metastasis, or a metastatic lesion or deposit, refers to a kidney cancer cell, at least in this situation, a kidney cancer cell that has spread outside of the kidney where it started to other organs or other parts of the body. So if you have a lung lesion that is not lung cancer, that is kidney cancer that has metastasized to the lung, or metastatic kidney cancer to the lung. So now you have advanced kidney cancer, or you're in a situation where you have metastatic kidney cancer, and what are my treatment options? Well, I'm just going to go some of the treatment options that we've kind of had in the past and currently use. I'm going to start with chemotherapy. Now, we commonly use chemotherapy interchangeably with targeted therapy, but they're really not one and the same. They're very different. Chemotherapy refers to drugs that are given through the vein typically, that get into the bloodstream and just travel everywhere throughout the bloodstream, hopefully hitting the cancer cells where they are, but also maybe targeting some of your healthy cells as well. It's more of a shotgun approach. And as Dr. Moore talked about, the kidney is actually not a very responsive, kidney tumors, are not very responsive to chemotherapy. And the reason for that is they have a lot of pumps in them, in the kidney cells, such that if the cancer therapy or the chemotherapy gets into the kidney cancer cell, it just pumps it back out again. So you can't keep it in the cell where it can have its action and destroy the cancer cells, if you will. It gets completely pumped out. So very chemo-resistant. And if you look at a lot of studies across the board, they really aren't great responders. We have tested chemotherapy in the past in kidney cancer, and really you're getting really poor response rates. Now, what does response rate mean? The technical way of looking at it is a person gets a response if their overall tumor burden, if you will, shrinks by about 30% or more. Okay, so that's what I would consider response rate. So if you look at chemotherapy trials, on average, you're looking at only about 6% response rates. That's only 6%. 6 out of 100 patients actually get a shrinkage of 30%. And if you look at overall survival or longevity, if you will, really not any better than not treating at all. So chemotherapy really wasn't a treatment option that was effective, and it is generally not used. There are a few situations that are being examined now in non-clear cell histologies where chemotherapy may be recommended or suggested. But a lot of that, again, is experimental or based on very little data. So I'm going to talk about immunotherapy as we knew about it in the past. Certainly immunotherapy is something that we have used before in kidney cancer, and it certainly was better than chemotherapy, which is why we used it. Now, why did we get into this idea of using the immune system in kidney cancer? Well, when Dr. Moore would take out kidneys, pathologists would look at it on the microscope and they'd look at the cells and they'd say, well, yeah, I see a lot of kidney cancer cells here, but I also see a lot of immune cells as well. The immune system, they're infiltrating the tumor. Now, why is that? And so obviously, with that evidence, the feeling was, well, the immune system is somehow involved or interacting with the kidney cancer. And if we kind of upregulated or gave a boost to the immune system, that there might be some activity on the kidney cancer. So we tried things like interleukin-2 and interferon alpha in terms of trying to, again, boost the immune system in a very non-specific manner as a way to try to affect upon the kidney cancer. Thank you. So interferon alpha, as I said, was one of those agents. Now, again, although it was used, response rates were very low, 2 to 3% by large. Durable response rates, so even though response rates were low for the 2 to 3% of the patients that actually did get a response, the ability to maintain a durable response was also pretty low, not very good. Overall, patients who did get interferon had a survival. Average patient who got interferon lived about 1 year, just over 1 year at 13 months. And that was in 2002, the data we had then. Now, I know a lot of people didn't respond, but if some people had stability of their cancer, if their cancer was not necessarily growing, that was also considered a bonus or a plus and a success. But really, giving interferon only delayed your cancer growth for about 5 months. Now, that is 5 months, but still, it's not fantastic. And certainly with some of our newer therapies, we've seen better data. Now, interferon is also a therapy that's given intravenously or under the skin, which isn't really all that favorable for patients. They also have to come in frequently to get that therapy. And the treatment itself can make you feel like you've got a really bad flu all the time. So it also had its fair share of toxicities, which, again, wasn't really doing the patients many favors, but again, at the time, 10, 12 years, 10, 15 years back, that's really the best stuff that we had, so it was given. Interleukin-2 is much more, potent immune stimulator, if you will. Certainly had better response rates, although I'd argue that they're still relatively low, about 15% response rate. However, there was a small population that ended up having durable response rates. So some patients actually living 5 years without the cancer actually showing up again. And certainly you could argue that this would be a cure for these patients as well. Now the thing is, though, that's only 5 patients out of 100 that would get the durable response rate. The issue with that is that we couldn't actually select. So if we put 100 people in this room that had this, and I gave it to all 100, 5 of them, would get a response, but 95 of them would not. 95 of them wouldn't benefit at all. And in fact, 2 of those 95 patients would actually die because of the therapy. It was really, really toxic. It required hospital admission and very, very regimented monitoring while you're receiving the therapy. So it's not really a treatment that we offer now, knowing that we have some of these other therapies. There are a few specialized centers that still offer it in North America. And really it's about selecting the right patient. And I think it's arguable that you can pick a patient who is very young and maybe has only disease in their lung or cancer that has spread to their lung, that you could treat them with this therapy. There was some retrospective data that suggests that that's the patient that may respond. And honestly, when you look at the average kidney cancer patient, they don't usually fall into that category. So it's not a treatment that we use very much, again, particularly with the newer agents we have. However, it is a drug that has shown very, very minor success. So that brings us to targeted therapy and really the treatment that we use today as standard of care. So just some general points. Targeted therapy attacks a couple of pathways, the agents that we use, and Dr. Moore did touch upon it. One is the VEGF pathway, the vascular endothelial growth factor pathway. The other is the mTOR pathway, right? And so how the VEGF inhibitors work, basically they inhibit angiogenesis. And Dr. Moore said they basically stop blood vessel growth. This tends to lead to more tumor shrinkage or tumor response, if you will. And then there's the mTOR inhibitors, and the way they work is they basically block signals for cell growth and proliferation. So there's other growth factors or requirements, proteins, cytokines that the cell requires to stimulate itself as well as other cells to continue to grow, and the mTOR inhibitors block that. Unfortunately, in doing so, you don't really get as great responses. The tumor doesn't shrink as much, but the tumor tends to stay stable and doesn't grow. So it's more of a tumor stasis agent. So what is angiogenesis? Just kind of talked about that. And here's just a nice picture showing that. Blood vessel growth there. And you see these little bubbles coming from the tumor or the green cells. And those are angiogenic factors or vascular endothelial growth factor. And those go towards the blood vessels, and the blood vessels start growing up into the cancer. Now, as Dr. Moore said, kidney cancer in particular is very, very vascular. It has a lot of blood vessels in and around it, and it needs those blood vessels to continue to grow and proliferate. And that's why blocking angiogenesis or shrinking the blood vessels here can actually have a good response, lead to good response for patients. And again, this is just another pictorial kind of showing, and if you'll focus on the right side of the picture, you'll see the mTOR molecule there in the blue. And again, the mTOR molecule, when stimulated, tells the DNA of the cell or the factory in the cell to start pumping out these growth factors that lead to cell survival, that lead to growth and proliferation of the cancer cell. And they go out into outside the cell and stimulate their buddies, and they get more and more cancer growth. And when you give agents that block that mTOR molecule, you certainly inhibit the ability of those growth factors to get out into the environment. So when it comes to targeted therapy, we basically give one agent at a time and sequentially. Combinations have really not worked in kidney cancer. They've generally led to really, really significant toxicity, so that they couldn't be tested further, or they've had similar results to monotherapy alone, but with just added toxicity. So we don't really combine these agents together because it just doesn't work. The typical standard in which we give is a VEGF inhibitor followed by an mTOR once you've progressed on that initial VEGF inhibitor. Okay, that's the standard here in Alberta, and that's what we offer patients as standard therapy. There are a few exceptions. Certainly if patients have a poor tolerance to the mTOR inhibitor in the second-line setting, or if we feel that they won't be a good candidate for that mTOR therapy, then we do have an option of another VEGF inhibitor that can be given in the second-line setting. Unfortunately, we don't really have a good standard of care based on great evidence for non-clear cell kidney cancer. Again, clear cell making up the large majority of kidney cancer. However, we do still treat them with targeted agents. As an international community looking at research, we are starting to target and look at specifically non-clear cell kidney cancer, and not just the general group, but looking at papillary, looking at chromophobe. You can imagine, though, with the rarity of these tumors coming up, that certainly does make it for difficult accrual and enrollment in clinical trials, but I think we are starting to try to do that. So hopefully we'll have a little bit more evidence for that in the future. Right now, I think we feel that targeted therapy is likely the best way to go, again, with few exceptions. So Dr. Moore did talk about prognostic factors, and in the advanced kidney cancer setting, we certainly do have prognostic factors as well. Now, what does that mean? Basically, it's looking at a group of features, both clinical, so things you may have, as well as maybe some blood work features as well, that help us determine how well you're going to do with treatment, or how long might you have? Now, some patients like to know this, some patients don't, so I always ask in case they do or don't. And this is data that's come from Alberta's own Daniel Hang, who's a medical oncologist in Calgary. He actually created this database of thousands, I'm not sure, but lots of patients, and looked at a lot of their factors to see, hey, can we help predict or prognosticate how patients are going to do? And he was able to identify these 6 criteria. And basically, for every criteria, you get a check mark or a point. And based on the number of points you have, you can prognosticate how well a patient might do. And this has actually been validated in both clear cell and non-clear cell patients. And these are the 6 here. So KPS refers to performance status, so how well are you functioning on a day-to-day basis. KPS refers to the Karnofsky Performance Status Scale, or Karnofsky Performance Scale, and less than 80% is just a criteria we give based on how well you're doing day-to-day, as I said. The time from diagnosis to treatment, if you were diagnosed and with kidney cancer and you went on systemic therapy within or less than a year, then that is a factor. Some patients get diagnosed with kidney cancer, have their kidney removed, and 2 years later, they end up having a lung lesion, which is kidney cancer. So that's a patient that would not fall into that criteria. Anemia refers to red blood cells or your hemoglobin being low in your blood. Hypercalcemia refers to calcium levels being elevated in your blood. Neutrophilia refers to a type of white blood cell called neutrophils being elevated in the blood. And thrombocytosis refers to platelets, another type of blood cell that's involved in clotting that's elevated in your blood. And when you look at the analysis that Dr. Heng did, based on how many criteria you have or how many factors you have, you would fall into a favorable, intermediate, or poor risk category. Those who had a favorable, who were favorable had none of those 6 factors. And their median overall survival, so the average patient would live about 43 months. Okay? If you were intermediate, which is where majority of patients end up falling, having 1 or 2 criteria, the average patient would live about 23 months. And the poor risk patients, unfortunately, if they had a lot of those criteria, it just meant that they were probably not doing very well. And their cancer is certainly aggressive. Their average survival is only about 8 months. So when we look at how we manage kidney cancer patients, at least here in Alberta, here's a little chart that I've modified based on other presentations in a general sense. And I did kind of make this for Alberta patients here. In the frontline setting, you can see if you were good or intermediate risk, there are really 2 options available to you, sunitinib and pazopanib. If you're a poor risk patient, temsirolimus is the one, I think, that has the best evidence for it. However, certainly sunitinib and pazopanib are other known options. In the second line setting, if you look at the bottom half of this chart here, really we're looking at the middle component, those patients who have failed VEGF receptor inhibition, because that is our standard frontline therapy. We really don't give cytokines anymore, and we really honestly don't really treat patients with mTOR inhibitors in the frontline setting. But if we were, there really is no standard of care that we can give afterwards. So it's usually either clinical trial, or maybe if we can get special permission, is to try one of the other tyrosine kinase inhibitors like Sutent, pazopanib, etc. Now, high-dose IL-2 I did have up there as an option, but really it isn't given at this center. It really does require specialized care and also a physician with specialized training, I think, to be able to manage these patients. We don't really have that level of expertise here, so we do try to, if patients are interested, we do try to point them in the direction so that they can get that treatment. Again, it is a rare patient that will get that or even consider that, particularly with some of the new things that we have coming out. And failed cytokines, again, because we don't give high-dose IL-2, we certainly don't give interferon anymore. That whole line there really isn't a treatment option. And failed mTORs. So frontline therapy. What do we have? What is our frontline therapy option here? And as I already have said, it's the VEGF inhibitor. And here really Sutent has become our standard of care frontline treatment option. Okay? Okay, it's a pill. You take it once daily. Many of you have been exposed to it, patients in the room, if not currently taking it. And we start off by putting patients on a 28-day on, followed by a 14-day off schedule. All right. Now that schedule can be varied, and as we've gotten more clinical experience as medical oncologists using this drug, we've realized that we can alter that schedule to try to keep patients on as long as we can and keep them off as minimal time as we can. But that time off has become important because it does offer patients the time to recover from some of the side effects of the treatment. But there is also some preliminary data saying that it's actually better for patients to be off therapy for a little bit of time because it kind of resets them to the effects of the sunitinib. Response rates from the registration trials from sunitinib are as high as 47%. That's really impressive. So about half the patients are getting a 30% reduction in tumor or better. Progression-free survival refers to the amount of time, the time from a patient starting treatment to the time that the cancer starts growing or progressing, and or death, I suppose. And that's 11 months. Now, if you remember back to the interferon data, we were giving interferon to patients, they were living 13 months. Okay? We're now getting progression-free survival. So patients' tumors are being controlled for 11 months before they start progressing. And there's still treatment after that. So certainly, when you look at overall survival range now being, if you use frontline sunitinib, some of the studies that we've got now with good data suggest a survival of 26 to 32 months. That's a lot better than 13 months back in 2002. So certainly these targeted therapies have contributed to improving patient survival and hopefully quality of life as well, because the treatments are certainly much better tolerated than some of these, some of the immune therapy that we had in the past. When it comes to side effects, again, something many of you are familiar with, high blood pressure, fatigue, diarrhea, hand-foot syndrome, which is basically irritation or damage to the skin at the palms of the hands or soles of the feet, mucositis, which is ulcers in the mouth or anywhere along the intestinal tract, and hypothyroidism. These are the common things that we see with kidney cancer. This is by no means an exhaustive list. I mean, there's a laundry list of side effects that can occur, but I think you'll find it with any drug. But these are the most common ones. These are the ones that are typically discussed with patients before starting them on treatment. Now, although you look at this, you may say, I don't want to deal with any of this. This is terrible. A lot of these toxicities are manageable. And they're quite manageable. We've gotten a lot better at managing these side effects as well, so we can keep patients on the drug so that they can better gain the benefits of the drug, gain the benefits of control of their cancer, and stay on the treatment and not have to stop because the side effects are getting too out of control. So we certainly have come a long way. Pazopanib is another VEGF-targeted therapy, and it's very similar to Sutent, and it acts in a similar way. It does affect the tyrosine kinase of the VEGF molecule binding to the VEGF receptor. This is also an oral therapy. It's taken once daily, but it's taken on a continuous basis. There's no breaks with pazopanib. And it does have comparable efficacy. In the registration trial, pazopanib was actually compared to placebo, so no therapy. And it actually did well. It had good response rates, around 30%, and the progression-free survival of 9.2 months, and an overall survival of 23 months. So very comparable data. Now you can say, well, those numbers are less than what I just showed for the Sutent data, but I want to keep in mind that you can't do cross-trial comparisons, right? So that was one trial with the Sutent data. This is another trial with pazopanib. You can't really compare them head-to-head, although that's often what people do. You really shouldn't, because they're completely separate trials. All right? I think it's impressive, though, to note that the numbers are around the same. And I think that's what I want you to kind of focus on there. Now, the company, pazopanib, when it came out, it did have similar efficacy, and so somebody said, well, can we not see which one's better? Can we not see if pazopanib is better than Sutent or Sutent better than pazopanib? So a study was put forth, and it was designed to show not if pazopanib was superior to sunitinib or equal, it was designed to show that it was not inferior. Now, you might all be looking at me saying, that's just semantics, Doc, what are you talking about? But really, it relates more to statistical events and statistical calculations. So the study had to have certain number of patients to show that the data was robust enough to prove what they wanted. And what they wanted to show is that pazopanib was not inferior to sunitinib. And they did show that. There's some question or some argument about how the statistics were done on that study and how the study was actually, how the data was actually put together. But the data is pretty close to being about equal. So you can argue that sunitinib and pazopanib are about the same, with similar response rates, progression-free survival, and overall survival. When it comes to an interesting point, though, is toxicity. And certainly with pazopanib, you can seem to get more liver toxicity with elevation of your liver enzymes. But other things that may be more prominent or affecting patients, such as fatigue, hypertension, hand-foot syndrome, diarrhea, they seem to be worse in patients who get Sutent. So a lot of patients may want to try pazopanib over sunitinib because it seems to be better tolerated, and you can argue, however, that it is about the same in terms of efficacy. It's a reasonable option for frontline therapy, and up until very recently, it wasn't available. Either or weren't available. Sutent was your frontline option, and if you were intolerant to Sutent, you could go on to get pazopanib. Recently, though, I think both have become options, and it's a reasonable discussion to have with your medical oncologist, right? So another frontline therapy that isn't really used much is temsirolimus, and this is actually an mTOR inhibitor. It's actually an agent that's given intravenously, and it's actually given weekly. So you get it through the vein, and you come in every week to get it. The data for temsirolimus to show its benefit was actually seen in a poor-risk patient population, and it was compared to interferon, right? So it wasn't compared to really any of the other targeted agents. But really, it's really the only study with robust enough data looking at poor-risk patients. Now, their criteria to define poor risk is different than the criteria that I showed you earlier. Slightly different, but it certainly does pertain to a poor population, and there is some overlap. And really, the study that validated temsirolimus had to have patients that had 3 of the 6 poor-risk criteria as identified on this slide. And when you look at the results, certainly patients who got temsirolimus versus interferon did better. Not only in terms of longevity, but they did have better quality of life while on the treatment. Now, the toxicities of temsirolimus were rash, some swelling, and some metabolic abnormalities related to sugar management and lipid abnormalities. But overall, not bad in terms of tolerance. Again, you're looking at a patient population that's typically not going to do well. As you can see, the overall survival is less than a year. But, not a bad therapy to give. Now, it is, however, rarely used. Now, why is that? Well, oftentimes patients who are not feeling all that well and that have all these criteria, they don't really want to be coming into the cancer center twice a week because they need to see us one day, we need to review them, make sure their blood work's doing all right, etc. And then the next day they need to come in to get their treatment. So that's 2 trips to the cancer center every week on an ongoing basis. I think a lot of patients shy away from that for that reason. In addition, we do have some subgroup analysis data, as well as data from an expanded access program showing that sunitinib can be given to a poor risk population of patients and show similar efficacy or still benefit to patients. So we tend to use sunitinib in these situations because patients don't have to come in as frequently. It's a pill, they don't have to get poked. It's a bit of a trade-off, if you will, but it's just generally a practice that I think we've come to follow. So what about second-line therapy? What happens if patients got any one of those agents I just talked about, but their cancer started growing? So, i.e., the therapy they were on is no longer effective. Well, the standard of care here in Alberta is with an mTOR agent, and that's everolimus. Okay? Everolimus was identified as the second-line therapy in a clinical trial that looked at patients who had previously received a VEGF targeted therapy and then went on to get everolimus or placebo. And if you look at my second point here, progression-free survival certainly was better for the everolimus, i.e. patients had better control of the disease or more control of the disease for a longer period of time compared to not getting anything at all. But again, as I alluded to earlier, these mTORs don't really give you a great response rate. So the response rate, that means, again, patients who actually had shrinkage of their tumor beyond 30%, was only 1 to 3%. So, I mean, that's not really robust. So again, this is a drug that just kind of keeps things the same. However, it can control the cancer, and it does control it better than giving them nothing at all. The other thing with everolimus is it did benefit all risk groups, so favorable, intermediate, or poor risk. In terms of toxicities, it can lead to a fair amount of muscle weakness. It can cause ulcers in the mouth, can reduce your blood levels, cause anemia, and it can also cause the sugar and lipid abnormalities that I talked about with temsirolimus as well. The big thing with everolimus that we worry about as clinicians is the development of something called pneumonitis. Again, it only happens, you can say it only happens in about 14% of patients, but I think that's relatively high. And sometimes the pneumonitis can be quite severe and be very debilitating for patients. So it is something we get concerned about. And if somebody does have poor lung function or severe COPD or lung disease of some kind, we may want to shy away from using the mTOR just because the chance of them getting pneumonitis might be high enough such that it could end up being quite problematic for that patient. So another second-line therapy is axitinib, and this is also available here in Alberta, but only in patients who cannot tolerate everolimus, having been on treatment with it, or patients we think will not tolerate everolimus for the reasons as I just spoke about, chronic lung disease or COPD. It is, however, targeted at the VEGF system, so it does inhibit the VEGF receptor. And it was compared in a trial in the second-line setting to sorafenib. Sorafenib is also a VEGF receptor inhibitor, but not one that we use commonly or have the ability to use because it's really funded only in patients who have previously received cytokines. But in the second-line setting, a major study was done that compared axitinib to sorafenib that showed a superiority of axitinib to sorafenib with respect to response rates and progression-free survival. Overall survival, however, didn't really pan out. It's about the same in both agents. What does that mean? We don't know, but we do still think that patients do derive some benefit from axitinib. Was there other treatments after patients received either axitinib or sunitinib that complicated the overall survival results? I think that data is not yet available. At least I haven't seen it. But it is still an option because it does provide control of disease and it does improve progression-free survival. In patients who had, the study did include a number of patients with variable past treatments. So if you looked at the group of patients that had sunitinib only in the frontline setting, patients' progression-free survival was 4.8 months, which is very comparable to the everolimus that was 4.9 months. Now I'm doing a cross-trial comparison, which I told you we shouldn't really do, but it's interesting that the numbers are very similar. And we know that from other data that we've seen that using axitinib, the agent that you used in the frontline setting has no bearing on how you'll do in the second-line setting. So let's say you got sunitinib or pazopanib in the frontline setting and you did really well and you had disease control for 2 years. That doesn't mean that if you went and you said, well, I did very well with the VEGF treatment, should I get a VEGF treatment in the second-line setting and go with axitinib, right? It doesn't actually correlate that way. So it doesn't matter what you got in the frontline setting or how well you did with the frontline setting, I should say. The mTOR or the axitinib acts independent of how you did in the first-line setting. Now, when it comes to axitinib, again, there's no direct comparison of axitinib and everolimus, so we really don't know the answer of which is better. Just based on the way things are funded and what we have available, axitinib is only available to patients who cannot get everolimus or cannot tolerate everolimus. And with respect to toxicities, axitinib is very similar to the other VEGF receptor inhibitors. High blood pressure, diarrhea, fatigue, as well as some appetite and weight loss issues are some of the common ones there. So third-line therapy, what about after all that? What do we have available? Clinical trial? Or we re-challenge you with something that you had previously? So unfortunately, when it comes to funding, we don't have anything beyond the second-line setting. So we do try to have clinical trials here at the Cross that we can enroll patients in. We certainly do have a few, and we've had some in the third-line setting, or studies in the second-line setting that would maybe make them eligible for other third-line therapy later on. But in the absence of them being able to enroll in a clinical trial, we really don't have a lot for patients. So it really is an unmet need, because what we're finding is, as we're using these drugs that I've just discussed, we are helping patients live longer. And if they're living longer, they're getting to the point where they can consider third-line therapy. So we need to really address this. And part of addressing that is looking at new options. And one of the really new options that's come to light lately has been immunotherapy. And kind of this rise again, as we've learned and understand more about how the immune system works, we've identified ways in which we can maybe work the immune system to help us with the management of kidney cancer. And the... Did I go too far ahead? No. All right, thanks. So some of the new immune-based strategies actually, one of them is something called the programmed death 1 molecule or inhibitor. Now that sounds kind of ominous, but really what it's doing is it's using kind of turning on the T cell, or the driver of the immune system that kind of recognizes and destroys foreign cells or cells that should not be in the body. The other thing that we're going to look at is vaccine therapies. There's two different kinds. There's the autologous vaccines, so vaccines that are derived, that are very personalized, where we take patient-specific tumor, kind of work that up, create a vaccine for it, and inject it back into patients. Or the multi-peptide vaccines that are just kind of off the shelf. We kind of generalize a vaccine that targets general kidney cancer proteins. The key thing that I want to mention with these treatments is that they all target the body's weapon against cancer, and that's the T cell. And so I'm going to stop here and I'm going to just turn on a video. It's about 7 or 8 minutes long, and it's just a nice primer. It's something I found on YouTube. It's not proprietary. It's available on Nature. So Brian's going to cue you, and it's just going to tell us a little bit more, help us understand a little bit more about immunotherapy.
Produced with exclusive support from Bavarian Nordic and Dendreon.
Throughout our lives, the cells in our body grow and divide. But when cells start dividing and spreading uncontrollably, they become cancerous. There are more than 200 different types of cancer, and scientists are continually developing and testing new ways to treat them. Most cancer therapies involve drugs designed to kill the rapidly dividing cells. This is what chemotherapy does. But there is a different approach called immunotherapy. Immunotherapy uses the body's own immune system to fight cancer. This involves activating immune cells and getting them to recognize the cancer tissue as different from normal body cells. This isn't easy, but recently the field has had some success. The FDA has approved several new drugs, and with more drugs in clinical trials, some say we are entering a new era of anti-cancer immunotherapy. The idea goes back to the late 19th century, to an American surgeon named William Coley. He injected bacteria into tumours and watched them shrink. The bacteria, it seemed, were provoking an immune response. But our immune system is highly complex, and for most of the 20th century, scientists struggled to turn Coley's observations into effective cancer treatments. But after decades of learning about the immune system, a variety of immunotherapies are finally making their way to the clinic. We can divide them into 4 general strategies: non-specific immune stimulation, adoptive cell transfer, immune checkpoint blockades, and vaccination strategies. The first, non-specific immune stimulation, is used to give a general boost to the immune system in vivo. To do this, some of the many cells that make up the immune system, such as these antigen-presenting cells, need to be activated. Researchers can do this by injecting molecules that bind to receptors in the cell membrane. The activated cells then alert other immune cells, such as these T cells. T cells are the main players in the fight against cancer. When activated, they can attack and kill tumour cells. For full activation, small cell signalling molecules called cytokines are needed. 2 cytokines, interferon alpha and interleukin-2, have been developed as drugs and approved for use against some forms of cancer, including melanoma. Another way to stimulate immune cells in vivo is to inject bacteria, like William Coley did. This has led to a rather surprising use of the BCG vaccine. BCG is normally given to children as protection against tuberculosis, but scientists have found that the weakened bacteria in the vaccine can also help patients with bladder cancer. The bacteria appear to cause inflammation, which increases the number of immune cells around the cancer, helping them to home in on their target. Non-specific immunity can also be achieved by removing so-called immune checkpoint blockades. These blockades normally dampen down the immune response to prevent collateral damage to healthy tissue. But to fight cancer, scientists need to remove some of these blockades to make the immune response stronger. The antibody ipilimumab, also known as Yervoy, targets a blockade molecule called CTLA-4. It got FDA approval for patients with advanced stage melanoma in summer 2011, and it's being tested for several other types of cancer. Activating immune cells inside the body can be difficult, but the next strategy, adoptive cell transfer, combats this by extracting the immune cells from the patient and activating them outside the body. It enables researchers to specifically target the cancer tissue. One approach is to take immune cells directly from the tumour. It's difficult to extract enough cells, but the advantage is that the cells have already learnt to recognise the tumour. Taking cells from the blood is much easier, but then you've got to use genetic engineering to arm them with tumour-specific receptors. Either way, the cells are activated using cytokines and then multiplied in petri dishes before being reintroduced to the patient. At the moment, this approach is experimental. The fourth strategy uses vaccinations. Unlike the BCG vaccine that we mentioned earlier, and which targets the immune system in a general way, these vaccines are used to direct immune cells very specifically to the cancer tissue. Several viral vaccines have shown promising results in clinical trials. For example, a weakened version of the herpes simplex virus, modified to produce an immune-stimulating factor, is being developed for melanoma and head and neck cancer. It's also possible to vaccinate with a patient's own tumour cells. Some cells are extracted, irradiated to stop them from spreading, and then engineered to secrete activating growth factors. When the cells are injected back into the patient, the growth factors alert the immune system to the cancer. But it's also possible to vaccinate with a person's own immune cells. For example, antigen-presenting cells can be taken from patients, matured outside the body, and loaded with tumour antigen. When the cells are reintroduced to the patient, the antigen stimulates other immune cells and helps them to recognise the tumour. The first vaccine of this type received FDA approval in 2010 for the treatment of some prostate cancers. It's known as Provenge or Sipuleucel-T. The other vaccination approaches are still experimental. The last few years have seen many promising developments in anti-cancer immunotherapies, but there's still much work to do. To help get drugs from the bench, through clinical trials and to the bedside, scientists need to find better ways to judge the success of immunotherapies in patients and to work out the best dose. Right now, it's difficult to predict who might respond to a particular treatment, and some responses are only short-lived. If these hurdles can be overcome, then many more cancer patients could benefit from strategies that boost their immune system.
Produced with exclusive support from Bavarian Nordic and Dendreon.
So, well, hopefully that was a benefit to you to kind of give you some basics on what immunotherapy is and the different kinds of immunotherapy there are. There's really two kinds that I'm going to be speaking about next in my few slides. And the new things that have come about, I mean, I already talked about interferon and IL-2, and that was one of the non-specific immune stimulators. What I'm going to speak about now is the checkpoint inhibitors, or checkpoint blockade. Now really, I guess one way you can look at it is, like in a car, there's a brake and there's a gas pedal. You got to keep both of them balanced to get somewhere. You can't just step on the gas and then things happen, right? You got to brake eventually. And the same thing, you can't just have the brakes on all the time, otherwise you'll never get anywhere. So there really is a balance between the two. And that's what this checkpoint blockade is trying to address, okay? I guess you could say when a cancer cell or when a foreign body is introduced into your system, there's different proteins that are taken up by cells like the antigen presenting cell that are then expressed on the surface of the cell. And those proteins or molecules that are on the surface of the cell, they get recognized by the T cell. And if the T cell says, hey, look, this is foreign, it has receptors that recognizes these as being foreign and says, I've got to do something about this, you've got to go. All right, quite simply. And that's the tumor cell. But the tumor cell is smart. And it's learned a way to kind of camouflage itself. Although it is recognized as foreign, it finds a way to kind of turn off the T cell and put the brakes on it. And there's these molecules that are on the surface of the T cell and also on the surface of your normal cells, non-cancer cells, but normal cells in your body that express these proteins. And when the T cell recognizes one of your normal body cells, it says, oh, you're not something I've got to destroy. You're safe. So it just goes away and it leaves it alone. Cancer cells have found a way to put those molecules on themselves. Brian, could you advance the slide, please? All right, could you go back, actually? That's fine. So basically, cancer cells have found a way to basically mask themselves. So they basically turn off the T cell, so the T cell doesn't have a way of acting on a cancer cell. Now, what do these new therapies do? These checkpoint inhibitors, they interfere with that off-switch process. They block the tumor cell, or they basically block the T cell from being able to say, hey, listen, you're okay. And therefore, they turn on the T cell, they activate the T cell so it has effect on the tumor cell. All right, does that make sense? All right. So a couple of these checkpoint inhibitors are, apologize for that slide. One of these drugs is nivolumab, and this is a PD-1 inhibitor, and this is probably one that's been probably best studied in kidney cancer with the best results so far by itself. And based on some preliminary data in a phase 1 study, there's essentially there's phases to studies. Phase 1 is the earliest phase where you're trying to see if this drug actually has some kind of benefit or some response on patients and figuring out what the doses of the drug that should be given to these patients. So you're looking usually at a patient population that's heavily pretreated. And in the nivolumab study, the phase 1 study, you had 34 patients with metastatic kidney cancer that were put on this study. Again, patients who had at least, about half of them had at least 3 or more therapies. All right, so again, patients who have been through a fair amount of treatment. And what they found is by giving them nivolumab, they actually, majority of them were living 1 or 2 years longer. That's survival. That's better. And that's patients who've received 3 therapies. You don't commonly see that, right? So again, very encouraging results. And they said, we need to put this into a bigger study, a more robust study where we can actually say, hey, this is really going to help patients. The interesting thing with this is those patients that did get response had very durable responses as well. So it's not just that they're getting shrinkage of their tumor, 30% of them did, but they were getting that benefit that lasted them a long time. So again, very interesting data that needed to be examined further. All right. So there's some phase 2 data that came out with nivolumab alone as well. Again, in maybe less pretreated patients who maybe had 1, maybe 2 other treatments ahead of prior. And what they found is that, again, progression-free survival wasn't great. It was only 4 months. And response rates were around 20 months, and that was irrespective of whatever dose of nivolumab they ended up using. But again, the key thing here is that the patients that did respond had very durable responses. You can see here on the graph on the side, actually the overall survival on this study of patients was 18 to 25 months. Again, and that's in a patient population that's second, maybe even third line therapy. You can see on the side, again, these are cross-trial comparisons. Again, I know you're not supposed to do that, but it was interesting. This was presented by Dr. Harshman at ASCO just this past year, which was in June. The nivolumab data, you can see actually in this setting, and compared to other drugs in the second-line setting, like axitinib, like temsirolimus, like everolimus, was doing much better in terms of giving patients that overall survival. So again, very intriguing data, very promising data, and so certainly things that we're trying to examine further. Right. So again, if you recall back to the video, there was another drug that they referred to called ipilimumab, and that binds the CTLA4 molecule here. It kind of blocks that effect to mask the cancer cell. And so the thought was combining nivolumab, which was a PD-1 molecule blocker, with ipilimumab, which was a CTLA4 blocker. So having two different checkpoint inhibitors being blocked to kind of amplify the effect of this immune therapy. And so this was the study, it was a phase 1 study that was presented at ASCO, and again, looking at patients who got different combinations of the nivolumab, ipilimumab, and looking at their results. All right. Next slide, please. And the results were actually really interesting in that the combination of using both actually led to fairly high response rates, 43 to 48%, the combination. But if you look back at the single agent nivolumab, and there was a study that I didn't show here that looked at single agent ipilimumab, the single agent activity wasn't really anywhere near as high as that. And in fact, you could argue that it was perhaps more than additive, so there's maybe even a synergistic effect of having them both on there together. The other thing that they saw is, again, that some very, very durable responses. Patients would get a response to treatment, and they would maintain that. Some patients would have this maintained response even though they stopped the immune therapy as well. Now, why that's happening, we don't know. Again, something we need to study more. But very, very promising results. No complete responses were seen on this study. However, does it matter? I mean, if your disease is controlled, you may have some fleck of something in your lungs, and it's staying the same for months and months and months at end. Is this now not necessarily something we're trying to cure? As I said, it's something we're trying to control. And if your cancer is controlled, I still think that's a success. Right? There are toxicities with these drugs, though, and they are directed at basically over or ramping up your immune system so the body starts attacking itself. And it can affect a number of different systems within your body. Right? So that is something that is examined and looked at very carefully. These treatments aren't without toxicity, but there are ways to manage them. Okay? And sometimes it's a matter of a patient having a huge immune response, having toxicity, stopping their treatment, managing the toxicities. But while you're managing the toxicities, they're still maintaining those durable responses. So that's the hope, and I think that's where a lot of this therapy is headed right now. Next slide, please. So what are some of the next steps with this drug? Well, one thing was saying, hey, well, let's compare this drug actively to what our standard of care is. And the standard of care in the second line setting was everolimus. So there is a study that's now closed that we participated in here at the Cross Cancer Institute, putting a few patients on, comparing everolimus to nivolumab. So we're waiting for the results. But I think this study is a very, very important study because it actually will bring immunotherapy into our armamentum so that we can start using it, or at least start rallying the government to start funding it so that we can use it for our patients. Okay? Obviously, results pending. If you can go back, Brian. The other thing is a nivolumab plus ipilimumab study compared to Sutent alone. This is a study that's opening up in late 2014, early 2015. It is a study that we will have here at the Cross, but it is looking at patients who have not been treated before. Okay. There are certainly other drugs and other studies forthcoming in something in a different type of agent, not a PD-1 inhibitor, but a PD-L1 inhibitor. But we don't have anything on our horizon just yet, but we're hoping. Next slide, please. We're just moving along here. So vaccine therapy is another therapy that's kind of got a little bit of swell lately with kidney cancer. And there's two different agents, the IMA 901 and the AGS 003. Next slide, please. The IMA 901, this is kind of again, off the shelf, if you will, type of a vaccine. And basically took a look at a number of different proteins that were expressed in kidney cancer cells, a number of different proteins that were expressed on normal human cells, and really trying to tease out what might be more specific to kidney cancer in general, not looking at a specific patient and what their kidney cancer is doing, but looking at a number of different kidney cancers and what's very common to all of those. And creating a vaccine that targets proteins that are generally presented on kidney cancer cells. And what they do is they basically inject this vaccine into patients, and that primes their immune system to recognize those common proteins. And in recognizing those common proteins, the immune system can now attack existing kidney cancer cells in the body. Right? We're currently awaiting results of a study there comparing the combination of the vaccine with sunitinib to sunitinib alone. Next slide, please. The AGS 003 vaccine, this is more of a personalized vaccine where we actually take tumor from a patient and we analyze it. We basically introduce it to immune cells that are taken from the patient themselves and get them to recognize the kidney cancer specific proteins from your tumor, and then inject those immune cells back into the patient so that those immune cells can now stimulate the existing immune system in the body to attack that specific kidney cancer in your body. So it's very personalized, and again, its preliminary data actually was tested in patients who were poor or intermediate risk, so patients who not necessarily have as good survival results, and actually they had tremendous results based on a very small phase 2 study where patient survival was quadrupled or quintupled. So they've taken that, if you don't mind, next slide please, to this phase 3 study called the ADAPT study, basically looking at patients and randomizing them 2-to-1 fashion to either the vaccine plus sunitinib or sunitinib alone. And results of this are still pending. Next slide. So, I told you ahead of time I tend to talk a lot, and I apologize for keeping you, but really what I wanted to talk to you about today was looking at targeted therapy and what we have available. And I did go over that. Really our standard is a VEGF inhibitor, usually Sutent, followed by an mTOR inhibitor, which is everolimus. With a slight variation, we can give axitinib if a patient's intolerant to the everolimus. The treatment's generally well tolerated. All right? It is a matter of managing these toxicities, but I think we've gotten very good at doing so. We certainly are experienced here, participating in the original studies that were done back in the mid-2000s. So I think we do care for patients very well when we give them targeted therapy, and I think our patients are getting that benefit from this treatment. I think the interesting stuff right now, though, in kidney cancer certainly is immune therapy and how to use it. The responses are modest at times, you could say, comparable to some of the other agents that we're using in the targeted realm, but they're very durable, and I think that's the most exciting thing about it. Patients are maintaining this response for a long time, and certainly as we start to use these agents more and we collect more data in clinical trial setting, I think we'll get better at using them. We'll know where to use them and which patients to select for that would benefit from them. And I think in the end, it's just about selecting the right patient. So clinical trials, I think, where we can, is the best way to go. That's it. Any